Okay, everybody, how's it? Welcome again. We will continue our discussion on abnormal psychology. We first discussed stress disorders, then anxiety disorders. Now we will be talking about dissociative disorders, somatoform, as well as what was formerly referred to as psychosomatic disorders. So let's take a look at those. All righty. And here we go. Okay. Um, Somatic symptom and related disorders, as well as what's used to be generally referred to as psychosomatic disorders, but now referred to as psychological factors affecting health. Alrighty, I guess we don't call it psychosomatic because it'll be kind of confusing with somatic symptom disorders. That said, I don't know if it's cleared it up that much, but I that's my mission to try to clear this stuff up. Alrighty. So, without further ado, let's start with dissociative disorders. Now, dissociative disorders, actually, dissociative and somatic symptom disorders are two groups of disorders. Generally, you're not going to run into as much. Okay, there are still people who suffer from these disorders, but they tend to be a low probability disorders in terms of what you'll encounter. Alrighty. Now, dissociative symptoms are very frequent, but in terms of in things like anxiety disorders, certain psychotic disorders, very commonly demonstrate dissociative symptoms. But in terms of this dissociative diagnoses that we're going to go over, not as common. Far more, seemingly far more common in the early part of the 20th century, and certainly written about quite frequently. But as far as the rest of the 20th century and into the 21st, you don't see the prevalence of these disorders nearly. They are far more rare, less common, and also the focus of research much less so on these in these areas. But for psychological factors affecting health, clearly a huge area, growing area, and tons of empirical support showing the impact of psychological factors and how they affect things such as heart disease, cancer, and so on. So I'm just going to skip this discussion against. Alrighty, well, to start off our discussion on dissociative disorders, Uncle Vince is going to be reading you a DSM bedtime story. Alrighty, lucky you. Well, it's not exactly a bedtime story, and I'm not Uncle Vince. But let me read this story from the case book. It's DSM-4 case book, but certainly the criteria for suffering from DID is very similar. So here is the case of Mary Crike Contrary. Alrighty, Mary Kendall is a 35-year-old social worker who was referred to a psychiatrist for treatment of chronic pain caused by a reflex sympathetic dystrophy in her right forearm and hand. She had a complex medical history that included asthma, migraine headaches, diabetes mellitus, and obesity. She was found to be highly hypnotizable, something to take note of, and quickly learned to control her pain with self hypnosis. Another thing to take note of. Mary was quite competent in her work, but had a rather kind of empty personal life. She had been married briefly and divorced 10 years earlier, and she had little interest in remarrying. She spent most of her free time volunteering in a hospital. As a thorough psychiatric evaluation continued, she reported the strange observation that on many occasions, when she returned home from work, the gas tank of the car was nearly full. Yet, when she got into the car to go to work the next day, it was half empty. Hmm. She began to keep track of the odometer and discovered that on many nights, 50 to 100 miles would have been clocked on the car overnight, although she had no memory of driving it anywhere. Further questioning revealed that she had gaps in her memory for large parts of her childhood. Interesting. Because of the gaps in her memory, the physician suspected a dissociative disorder, but it was only after several months of hypnotic treatment for pain control that the explanation for the lost time emerged. During a hypnotic induction, the physician again asked about the lost time. Mystery. Suddenly, a different voice responded, "It's about time you knew about me." I don't know if that's what it sounded like, but sounds that's what it sounds like in my head. The alter personality with a slightly different name, Marion, now spoke and described the drives she took at night, which were retreats to the nearby hills and seashore to work out problems. Work out problems. As the psychiatrist got to know Marion over time, it was apparent that she was as abrupt and hostile as Mary was compliant and concerned about others. Marion considered Mary to be rather pathetic and far too interested in pleasing, and said that worrying about anyone but yourself is a waste of time. In the course of therapy, some six other personalities emerged, roughly organized around the lines of a dependent aggressive continuum. Considerable tension and disagreement emerged among these personalities, each of which was rather two dimensional. Competition for control of time out, for time out was frequent, and Marion would provoke situations that frightened the others, including one who identified herself as a 6-year-old child. The subjective experience of distinction among some of the personality states was underscored when one rather hostile alter personality made a suicide threat. The therapist insisted on discussing this with other personalities, and she objected that to do so would be a quote violation of the doctor patient confidentiality. The memories that emerged with these dissociated personalities included recollections of physical and sexual abuse at the hands of her father and others, and considerable guilt about not having protected other children in the family from such abuse. Mary recalled her mother as being infrequently abusive, but quite dependent, and forcing Mary to cook and clean from a very early age. After 4 years of psychotherapy, Mary gradually integrated portions of these personality states. Two similar personalities merged, although she remained partially dissociated. The personality states were aware of one another and continued to, quote, fight with each other periodically. That is the story of Mary Quite Contrary. All righty then. So that is a story of it's been traditionally referred to as multiple personality disorder. Okay. Now, in the DSM, the current term is dissociative identity disorder. Okay, you rarely hear people using that term. Multiple personality has kind of stuck with the general public, but the new term is dissociative identity disorder. Okay, it's characterized, as many of you all are probably well familiar, by the occurrence of two or more distinct identities in the same individual. Okay, two or more identities. The number of identities in some reported cases have included anywhere upwards of 12 to 15 or hundreds. Okay, a red flag, as kind of indicated here, of a person suffering from DID are memory gaps. Yeah, like for example, with Mary Quite Contrary, wondering how I just came home with a full tank, and when I go to my car the next morning, it indicates 50 or 100 miles have been driven. Things like that. Yeah, the idea of, in theory, of these other distinct identities is that there are ways to buffer anxiety. Yeah. So in the case of Mary Quite Contrary, right, who's very people pleasing, taking care of people, non-confrontational, that the idea that to be confrontational, you had to assert herself would instill so much anxiety that she needed Marion, right? The more feisty personality. That's the only way she could experience being assertive. Yeah, that's the idea. So, if someone demonstrates these characteristics, they need to be suffering from social occupational problems or distress. Alrighty. And when confronted with these kinds of symptoms, you need to be sure to differentiate it from, let's say, drug use, a psychotic disorder. Yeah, someone is suffering from, say, schizophrenia, and they believe they're more than one entity. Let's see, and also cultural factors. Yeah, so you want to be checked to see, check about religious, cultural beliefs about spirits and other personalities, as opposed to actual psychic or conscious dissociation. Okay, let me bypass this. Reportedly, personalities varied, as in the case with Mary, individuals at different ages, sometimes genders. Some may be elderly people, some may be if the person's an adult, middle-aged adult. Some of their other personas, maybe elderly people or children. They may even different race and ethnicity. Some case studies have suggested or claimed different psychological test results. In some cases, will claim different eyeglass prescriptions or handedness, yeah, being left or right-handed. Um, Very kind of interesting kind of case studies and reports. Alrighty. So how does dissociative identity, at least in theory, come about? The theory is that individuals probably experience some kind of childhood trauma, okay, physical, sexual, whatever, something along those lines, and that the emergence of other personas, yeah, um, serve to function um, the containment or the experience of different emotions which the primary individual, yeah, um, the actual individual can't experience. Yeah, maybe it's anger about um, people not being fair, or wanting to be comical or silly as a way of coping with things, but the original person can't allow themselves to be angry or to be comical or what have you. So they come up with different personas to contain those emotions, to have those emotions. That's the theory. Um, it's also theorized that only certain types of people will demonstrate this. Yeah, clearly. Well, you can say that for every diagnosis. But what is unique with DID uh, um, is that people who are likely to become multiple personality individuals are those who are susceptible to self-hypnosis. Yeah, that they can induce themselves into other levels of consciousness. Alrighty, and that this ability to hypnotize oneself, yeah, is probably the origin or the genesis of creating all these identities, yeah, to contain certain experiences, wishes, impulse, and feelings. Alrighty then. Well, is this a valid diagnosis? We're certainly going to have a debate on this matter, um, and it's usually a very fun debate. But it is disputed. Although it is a diagnosis in DSM, it is certainly in dispute among mental health professionals as to whether it is a valid diagnosis and whether it should still be in the DSM. You know, Many argue that all you're really seeing is an individual's capacity to role play. Yeah, so kind of play pretend, but as adults. Yeah. But others will also submit that maybe there's an interpersonal dynamic going on in that the individuals being reinforced by an outside party to present their problems, or how they manage things in this manner. In particular, some therapists may be uh, encouraging and reinforcing some of their patients to present or think of their problems along these lines. Yeah. There's a culture bound characteristic of in terms of this disorder and its prevalence. Yeah, it's rarely found anywhere outside the U.S. I mean, there's some data to show that there may be increasing numbers in areas like Canada and the UK, but mostly it's North America. It's a North American phenomenon, which kind of leads to the question: why North America? And, well, there has been interesting speculations about how because in the Northern American continent, because it's so huge, right? There's this just general cultural notion that you can always reinvent yourself. Yeah, move to another state, move to another territory, and start a whole new life. And maybe this kind of cultural phenomenon in the U.S. and perhaps in Canada, I'm not as familiar with Canada whether that happens or not, but that idea that you can always move and start anew may have maybe the undercurrents for why some individuals might say, hey, you know what? I don't want to deal with this, but I'm going to start anew in a way intrapsychically as opposed to moving to a different state. Um, you know, and a lot of the theory is kind of based on on Freud's old notion of repression. Yeah, that We can repress anxiety. It's a defense mechanism. And then multiple personalities, kind of a, you could, for lack of a better term, advanced version of that defense mechanism, a version, maybe not fair to say advanced, but where you compartmentalize different experiences, wishes, and so on. Alrighty. False memory controversy is concerned with the possibility that, again, going back to certain therapists who endorse who have a lot of patients, coincidentally enough, with this disorder, may also be implanting false memories in these patients that they suffered childhood sexual trauma. And there's certainly research to support that you can induce people to reconstruct their memories for bad things like being lost or for some very negative events in their childhood, which may not have occurred. Alrighty. It's very easy to fake multiple personality. Just, read the criteria and do your thing. It's hard to tell whether someone's, how you can distinguish a malingerer from a non-malingerer. Alrighty. So those are some of the, I'm certainly presenting I just presented a lot of the counter arguments to its existence. That I will be fully transparent. My bias is I'm inclined to think that this is not a valid disorder. Okay. That said, I think I also offset it by I think I did a fair presentation of the criteria of the theory and so on. Yeah. So only time will tell whether DID will still be with us in the future. Dissociative amnesia. Okay, what is this? Well, think of well, you don't see it now because I think it's been an overused story gimmick. But back in the 70s and 80s, man, this was such a common TV episode situation. Yeah, someone losing their memory for something very specific, a specific event or specific person or specific issue. Yeah, and someone oddly enough can't remember an old lover. I mean, someone or someone they dated just a week ago. It's like, I don't know who you are, or they can't remember anything about their senior year, in high school, or yeah, just something, like some circumscribed area in their lives, a person, a period in their lives, a place, something like that. Yeah, and so, it's usually with the idea that so that's the notion, alrighty, that people will have these memory gaps. Very, and by the way, I don't want to come across like this. You certainly will run into cases like this, yeah. And very often the thing I was just making light of was that sometimes TV series would really take advantage of these kind of situations, but these situations can occur, and when they do occur, whatever person, place, or issue can't be remembered. Usually, the idea is that it's related to some traumatic or very stressful experience. Yeah, it can't be accounted for by just normal, simple forgetting, or there's no organic basis for it. Now, in these situations, the lost memory can often be reaccessed, and whatever is experienced can be reversible, but it often takes time. Yeah, days, weeks, sometimes years, depending on how difficult it is for the person to acknowledge something that they don't want to remember, seemingly don't want to. Well, and that's the idea, is that it's not that they're saying, "Oh, I don't want to talk about it." They're saying, "I can't remember it." Okay, so the treatment focused on making someone bring up to examine why they can't bring up something is an interesting question, actually. Um, because if they're now, how well, let me take a step back. To be diagnosed, it has to be affecting social occupational functioning, okay, or distressing them, all righty, that they can't remember. So if that's the case, right, the person would probably be coming to the therapist saying, this is affecting my relationship with my family, that I can't remember another family member, or it's distressing them so much that this big gap um, aspect of their childhood with their mother they can't remember, that that's the motivation to retrieve those memories, work on that. Yeah. But it could be an interesting issue, right? If the therapist, while doing this kind of work, either through hypnosis or through just controlled, conscious interviewing, um, starts coming across material that might be even more distressing, that maybe the person forgot this because it was serving a function, you know. Um, and it's kind of an interesting, just general psychotherapy question. If there's some material that people do not want to talk about, yeah, do not want to get into, should you get into it? Yeah. My guess, I'm not aware of any good research on it because I suspect there isn't any right now. But I suspect most therapists then let it go, right? Because a lot with the, not just to be, because it's easier, but with the idea that you want your work with the patient to be collaborative. Yeah, we're not psychic dentists. Yeah, it's not the idea of forcing things out of people's mouths like a tooth or bad memory if they don't want to. If they don't want to talk about it, then you leave it be. Yeah. So very interesting phenomenon. They come to you and then about this gap. And then if you explore that gap, what if it turns out that there's stuff that's really difficult and that it may be kind of interesting issue, more adaptive for the person just not to think about it? Well, I leave that to you. All righty. Depersonalization or derealization order disorder. All righty. Let me tell you another DSM story. All righty. So foggy student. Uh, so here's a story of foggy student. A 20-year-old male college student sought psychiatric consultation because he was worried that he might be going insane. For the past 2 years, he had experienced increasingly frequent episodes of feeling outside himself. These episodes were accompanied by a sense of deadness in his body. In addition, these periods were during these periods he was uncertain of his balance and frequently stumbled into furniture. This was more apt to occur in public, especially if he was somewhat anxious. During these episodes, he felt a lack of easy, natural control of his body, and his thoughts seemed foggy as well. In a way, that reminded him of having received intravenous anesthetic agents for an appendectomy some 5 years previously. The patient's subjective sense of lack of control was especially troublesome, and he would fight it by shaking his head and saying, "Stop," to himself. This would momentarily clear his mind and restore a sense of autonomy, but only temporarily, as the feelings of deadness and of being outside himself would return. Gradually, over a period of several hours, the unpleasant experiences would fade. The patient was anxious, however, about their return, and he found them increasing both frequency and duration. Oof. As at the time the patient came for treatment, he was experiencing these symptoms about twice a week, and each incident lasted from 3 to 4 hours. On several occasions, the episode had occurred while he was driving his car and was alone. Worried that he might have an accident, he had stopped driving unless someone accompanied him. He had stopped driving unless someone accompanied him. Increasingly, he had begun to discuss this problem with his girlfriend. Eventually, she had become less affectionate toward him, complaining that he had lost his sense of humor and was totally self preoccupied. She threatened to break off with him unless he changed, and she began to date other men. The patient's college grades remained unimpaired, interesting enough. They had, in fact, improved, wow, over the past 6 months as he was spending more time studying than had previously been the case. Although discouraged by his symptoms, he slept well at night, had noted no change in appetite, and had experienced no impairment in concentration. He was neither fatigued nor physically, quote unquote, edgy because of his worry. Because a cousin had been hospitalized for many years with severe mental illness, the patient had begun to wonder if a similar fate might befall him and sought direct reassurance on the matter. Very, very good case capturing this disorder, depersonalization and realization disorder. Okay, we spoke before about the experience of a dissociative symptom. So I'm not going to go over that again. But this is the idea that this is the most prevalent subjective experience, yeah, of being kind of experiencing things a little foggy or being disconnected from reality, sometimes feeling outside of themselves. This can be a very discombobulating, distressing experience for an individual. I mean, individuals can really feel like they're, losing their minds in circumstances like this. Yeah. They usually experience frequent, recurrent episodes. Um, and interesting enough, they are aware that what they're experiencing is not real. Yeah, they understand that as a symptom of something. Yeah, so they may go to a neurologist or general practitioner, and if those and if there aren't any clear organic causes, yeah, then they may refer to a psychiatrist or psychologist of, and this very well may be the diagnosis. Okay. This very rare. You won't see this very often. Alrighty, depersonalization, derealization, and it's aptly titled because it is this feeling that your sense of personal integrity, psychological conscious sense of who you are, and so on. And if you look, is disturbed, yeah, like you're looking down, watching yourself, um, things around you seem as though you're watching them on a movie screen, and so on. Alrighty, and again, you need to have a decrease in SO functioning. You know what that stands for, or distress. Okay, and we will next talk about somatic symptom and related disorders. Very interesting group of disorders which garnered a lot of attention, particularly by Freud and his disciples. Some of his disciples, not all of them, and was written about a lot in the early part of the 20th century. And there are at least reportedly more proportionately more cases. But now, this one of these are a group of disorders you rarely see. Oh, but you will on occasion. So that's why it's still in the DSM and it's still worthy of our discussion. But with that, let me pause. Uno momento. Okay, folks, thank you so much for that quick Red Bull break. So moving right on, right along, right on, right along. Somatic symptom and related disorders. Alrighty. In a nutshell, the disorders we're going to be looking at are disorders that involve the presentation of a physical, um, medical problem, but there's no organic basis to it. Alrighty. That the symptom that's being presented probably serves some kind of psychological function or need for the individual. That's the idea. Alrighty. There's either one or no organic basis, or it makes no medical sense, the particular symptom or problem that they're presenting. Alrighty. And, there isn't anything to be found. Now, we got to be careful with this, right? Because sometimes this is how new medical conditions are discovered. Just because something's new and we don't understand it or can't find it doesn't mean it doesn't exist. You got to be real careful with this. And this can sometimes happen in hospital settings, where patients, a physician, I'm not casting aspersions on physicians, but when they can't find any evidence of an underlying organic cause, or that what the person's presenting seems just odd and it doesn't fit with how the body works, or any theory of disease, the person may be referred to a psychologist or psychiatrist, because of concern that they're suffering from a somatic symptom disorder. But we got to be careful with that, yeah, because maybe someone is experiencing something that's novel and new, and we just don't understand it from a medical standpoint. Now, away from those situations, always to keep on the back burner, yeah, is coming back to these types of disorders. Okay. So one thing to be keep in mind is that the symptom is not purposefully produced. Okay, the individual is experiencing as something ego dystonic. Yeah, it's something apart from them. They don't want it. They don't think that whatever headaches or paralysis or blindness that they're experiencing is something they want. They're afraid of it, right? They're unhappy and afraid and distressed that they can't see, or that they feel paralysis from the wrist down. Okay. And we need to again differentiate this from what was traditionally referred to as psychosomatic disorders. Okay. And these are physical disorders in which psychological factors can be playing a causal or contributing role. Okay. So psychosomatic disorders are real physical medical conditions which may have a psychological causative factor or contributing factor. Okay, somatic symptom disorder, or what's traditionally referred to as hypochondriasis. Okay, I like to think of this as the Woody Allen disorder. This is where you have someone who's a hypochondriac, right? They are just obsessed about symptoms. And if they have if they sneeze, or if they have the slightest headache or slightest numbness somewhere, they start freaking out, and they start just obsessing about what these symptoms may be, about the symptoms, and over excessive concern about the symptoms. Okay. Sometimes the people have these concerns can last for years. Yeah. And it can be something that really is disruptive to their family and friends. Alrighty. Now, this presentation has to exist for at least 6 months. Alrighty. And you got to be sure to differentiate it from things such as depression. Right. Sometimes depressed people may be focused on a particular physical symptom, or some kind of psychotic or stress disorder, disorders. Okay. Now, that is to be distinguished from, it's very similar, but it is an important difference, illness anxiety disorder. Okay. With illness anxiety disorder, it's not just an obsession with the symptoms. Okay. With the former, it's what do these symptoms mean, and being more obsessed about the symptoms and concerned about the symptoms of rash or what have you. Here, it's to focus on an illness. Okay, so do I have this particular illness? Do I have this particular diagnosis? Yeah. Um, so there certainly may be complaints about relatively minor amount symptoms. Okay, but it's the idea that it's related to a fear of having whatever cancer or having AIDS or something. That seems to be so the focus is different. Alrighty, probably very similar psychological process at play, but it's here the distinction is what is the focus of interest. Okay. Um, with illness anxiety disorder, it also may serve a function. There's two different subtypes with two different, each with its own function clearly. One is to avoid any kind of care, and they're so afraid that it's cancer that they'll stay away from physicians and what have yous, or the opposite, seeking care. They're so concerned about having cancer, they think they have cancer, that they're constantly going from physician to physician to physician. Alrighty. Oddly enough, it can play in opposite directions. Yeah. But again, it's this obsession about having a particular diagnosis. Yeah. Uh, the concern, again, magical number 6 months, and you need to differentiate it against some of these other possible diagnoses. Alrighty. One of Freud's favorites to talk about was what was formerly known as conversion disorder. Okay. Now, it was called conversion because the idea was that if someone experienced a physical symptom that had an organic basis, like they said they were blind, they couldn't see, that they saw blackness, right? But there was no there's no evidence or sign of damage to the eye or any other kind of, well, probably back in the day, they couldn't tell if there was any kind of brain damage, but, there was no organic pathology neurological pathology to suggest that, to explain the blindness, but they said that they were blind. Now, that was a way to convert anxiety. All right. So if they're anxious about something they saw, like maybe they saw a loved one with their lover, and that so traumatized them, right? They became blind, or having paralysis, right, of the of the hand just from the wrist onward. Okay, which paralysis doesn't work that way, right? It works along damaged nerves, and the paralysis will be related to the region of the nerve damage. It won't just be like across the wrist where the wristwatch is. Alrighty. So when you got these presented medical and that they'll be distressed about being blind or distressed about not being able to move their hand. Yeah, they're not faking it. They are absolutely distressed about that. But there's no organic medical, it's almost essentially a physical impossibility that they could be experiencing what they're experiencing. Is Freud would posit, yeah, that this was probably a sign of a conversion disorder. Yeah, maybe with the paralysis in the hand from the wrist up, it's right across the wrist, clean cut across the wrist. That maybe it's because a classic Freud one. maybe concerns about masturbation, and because they masturbated and now they feel awful about it because they've committed a sin. So now they want to say, "Oh, I can't move my hand," something. I don't know if they do it in that voice, but that's what it always sounds like to me. They can't move their hands. So it's usually generally one complaint. It won't be blindness in the hand and paralysis, other paralysis. It will generally be one or the other. And Freud would posit that the nature of the complaint would be related to whatever trauma or stress may have induced um, the conversion symptom. It's now called functional neurological symptom disorder. Makes it much more uh, puts it into much more medicalese. Makes it sound like a medical problem more so than just this purely psychological problem. Alrighty, although in essence it's still viewed that way. Alrighty, because there's no organic medical basis for the symptom. Has to again appear SO functioning or distress, one or the other. And here's what I kind of spoke about earlier, right? This, what's in blue, no, you don't have paralysis like that, clean cut across here. Paralysis would be if these two nerves are damaged, then the paralysis would probably be in this area, right? If it was here and then here, the paralysis would be this way. It will be uneven, right? Right? It wouldn't be like cut right across there, right? Nice clean cut. Doesn't work that way. Factitious disorder. Okay, what is this? Well, that's one where they get the old term, which really captures what's going on. Here, someone is presenting faking symptoms, yeah, without any apparent incentive, like money or like they're suing someone or they're trying to stay out of jail or anything like that. There's no clear external incentive, but there seems to be a psychological need. Okay, so factitious disorder, popularly referred as Munchausen syndrome, is when someone presents that a lot of symptoms. They go to the doctor a lot, and by a lot, we're talking about like, what 80. Here's an example. I think I heard once. Someone who had 86 visits in a year. It could be much more than that. Yeah, but 86, that's a lot to me. I like once every year at best. That's a lot to me, but that's what you should be doing once to the dentist and then once to the general practitioner. Um, 86, so yeah, so um, it's when someone is presenting something of that sort. And it seems to be taken for a psychological need, for lack of a better way of expressing it, a need for attention, to be cared, to be taken seriously. Yeah. There's another very concerning version of this, which is Munchausen syndrome by proxy, where a parent um, takes a child in. And for some odd reason, I think whenever you hear these cases, so often it tends to be mothers who bring their children in, not fathers. I don't know, maybe because mother. Yeah, I'm not trying to pathologize women by suggesting that. I think it's just a simple phenomenon that women tend to be more the primary caretakers and fathers. Fathers are feh. I'm kidding. Anyhow, but that Munchausen syndrome by proxy is a very concerning one, where a mother is seen taking a child because for symptoms that the mother's reporting the child is experiencing. So the child is getting examined over and over and over and getting different treatments, possibly different medications. And what's really concerning about this disorder, and it can be undetected for a long period of time. It can be undetected when it's just Munchausen and the individual's doing it, but certainly with Munchausen by proxies, it can be. What's concerning is that the child had no choice in this matter, right? Not likely the child decided to, hey, let's start playing this. Um, it's not by their choice, but when children go through this kind of thing, depending on what treatments or medications they get, yeah, and or but actually probably more concerning, what the mother might do in order to induce the presentation of symptoms. Yeah, that's also occurred in some reported cases, right? If children seem emaciated and like they haven't eaten for a long period of time, yeah, could the mother be doing something to induce these kinds of physical problems? Alrighty. So if the child is sick for some other reasons, and if it was induced in some manner, by some way, nefarious way, by the mother, you know, Again, with the idea not so much to hurt the child, but so much that in terms of trying to gain the attention to take care of some psychological need for herself. Okay. Uh, I'm not ruling out that there are father cases, but whenever you hear these cases, are almost always mothers. But again, it's not to pathologize women. I think it's just more of a social phenomenon where usually mothers are the caretakers. Um, and this is to be distinguished from malingering. Okay. Now, malingering is not a disorder. Okay. It is a designation in the DSM, right? It's something you can record in a chart, and it's a category that is noted in the DSM, but it's not a diagnosis. What it is it is a situation where someone is purposefully fabricating symptoms, but not for psychological need, but for a clear external incentive, like money, stay out of jail, or what have you. Okay, like if they're presenting that they're mentally ill when they committed the crime, the insanity plea, but they're not. Okay. Now, the idea with a lot of these problems, such as conversion disorder, illness, anxiety disorder, and so on, is that these symptoms take care of represent an underlying conflict or um, emotion, negative emotion, or experience or memory that the client is having a hard time making sense of or dealing with. That by focusing on symptoms or the diagnosis or the perceived paralysis, like in conversion disorder and so on, that these are ways to kind of manage those feelings. Okay. Now, there are two terms that frequently come up when talking about these cases: primary gain and secondary gain. Okay. And the primary gain, right, with conversion disorder, right, that this is a way to symbolically keep the person's internal conflicts repressed. Okay. You notice a lot of psychoanalytic, psychodynamic kind of language being used because that's where a lot of the explanation for these phenomena come from. Okay. Behaviorism can explain these too. Yeah, that essentially the manifestation of symptoms and the attention people get from it can be things that are just reinforced, and they certainly can be. Yeah, you make an appointment, you say you have this problem, you get professionals attending to you. For some individuals, that can be incredibly reinforcing. Yeah, seeing the care that they get from uh, physicians or nurses, which they don't get at home. Yeah, it's hard for maybe many of us to be excited about the idea of going to a doctor's office and presenting a problem and maybe getting diagnosed and getting a medication. For most of us, that's kind of aversive. But for some individuals, yeah, who completely lack that in their lives, yeah, maybe they're completely, almost entirely isolated. Yeah. Not that isolated people always do this, but for people who may be experiencing this, they very well maybe they very well are in situations where they're isolated or have very minimal chances of getting interpersonal support and reinforcement, but they can if they go to the doctor. And that's the secondary gain that you want to look out for. Okay. Um, Alrighty then. So, what's this common biological treatments for these conditions? Antidepressants are often used. Apparently, very often, what may be corollary with these experiences will be depression. So that is certainly part of the work because clearly they probably are depressed about their symptoms. Um, Other forms of psychological treatment that seem to be effective: insight-oriented therapy, helping people recognize what other psychological issues are occurring. Now, just to oversimplify here, but just to get to a point, you know, treatment that tells a person you're faking it or you're making it up or your medical problem isn't real is probably not going to get you anywhere. All righty. People who believe in their symptoms. Yeah, I'm thinking, whether it's the conversion, illness, anxiety, or hypochondriac people, or the person even more like inclined to be fake, who's more arguably faking it. Yeah, the three others that I just mentioned, they're not faking it; they really believe it. But in the Munchausen's, where they are faking it, any of those individuals, you tell them that what they're presenting is not real, you're probably not going to see them again, right? Human beings are kind of funny that way. When you tell them that what they're presenting is not real, they kind of say, later's for you, right? Well, because the point is the way they're oriented right now, that's the only way they can get support. Yeah. Um, if you want to just get to it, right? The only way that you can feel like contact with people, right? A sense of concern or care, lack of a better term, love from other people is by doing this. So by telling them they're faking it, just see ya, ain't gonna happen. The probably the focus of treatment is if you recognize what's going on, is to try to find out, right? Work with the person, acknowledge their subjective experience. Yeah, you're not saying that, hey, what's going on there, conversion disorder, blindness is real. That's not for you to say, as a psychological expert, yeah, or a clinician. That's not your job. Yeah, if they ask you, don't you think it's real? Everyone doesn't believe me, blah, blah, blah. You can say, hey, look, and because it's true, right? As a psychologist, you're not positioned to answer that question. Yeah, what you are positioned is to help them to understand um, how they're presenting problems, right? Their symptoms and kinds of problems they're running into now, right? With physicians maybe not believing them, or yeah, I haven't mentioned this before, but they use the thing that will bring people into therapy would be the physicians into not believing them, or family or friends not believing them, or what have you, or Munchausen by proxy, they might get into some legal trouble, with how they're handling Munchausen by proxy, by how they're handling their children. They very well may be up on child abuse charges. So your job is to focus on supporting them in terms of helping them deal with what they're experiencing, but also ultimately finding out what are the underlying psychological stressors or trauma that they may have experienced that these symptoms may be helping them deal with, or and so on. And that takes a lot of work. It's usually a slow process. Yeah. But that's the way you can, from a psychological perspective, help them manage that. Yeah. So manage whatever trouble they're having right now with people not believing them, physicians, family, whatever. But then also, and how they can deal with that better. But then also to try to get at what may be happening. Yeah, and maybe as part of that process, gently presenting other things that you're understanding that they're going through, and helping them try to manage that as well. Yeah. Okay, and now for the third grouping, psychological factors affecting physical health. Alrighty. Now, what was formerly referred to as psychosomatic disorders, but now we call it psychological factors affecting physical health, just to not confuse it with those somatic disorders. These are disorders in which psychological factors are believed to play a causal or contributing role to health. Yeah, be it cancer, heart disease, hypertension, whatever. There are a number of really, and when you think about some of the major things that leads to mortality among adults in the U.S., like cancer, like heart disease, right? They're up there in the top three easily enough. Um, Psychological factors can have a huge play. Yeah, so you're not just left with your hypertension medication, or just just, but the incredibly necessary cancer medical treatment. There are also other things you can do psychologically, yeah, to help you, one, either manage your medical treatment, because going through cancer treatment is incredibly difficult. Yeah. Um, uh, but so managing, your actual medical treatment might be incredibly difficult. It's no walk in the park. When you're told that you got to change your diet, you got to exercise, you got to take medications, you got to go through cancer treatment. All of those things are incredibly difficult for people for a variety of reasons. Yeah. Sometimes it's just a matter of change. Just a matter of change. I mean, look at losing weight or exercise. That's hard for most Americans. Yeah, that's why I don't have to tell you the U.S. data on American health is horrible, right? If it were easy, we wouldn't be having these problems, obviously. So it's incredibly difficult, and that's where um, the mental health, if you decide to go down this road and become a mental health practitioner, that's where you can play a huge role. Yeah, you get someone from being morbidly obese or obese to average weight for their age and height. You may have saved their lives, right? That has a play in both cancer and heart disease, not to mention hypertension. Alrighty. So, but as I said, one is to help them manage going through something as difficult as the medical treatment, or to change their lives such that they won't need the medical treatments, or it decreases the probability or risk that they'll suffer from some particular disorder or disease. Okay, this is a huge area in psychology called health psychology. It's also referred to as behavioral medicine, and applies to a number of things, a number of areas, problems, and issues that, as I just mentioned. Not to mention things such as, headaches, migraines, tension headaches, and so on. And with that, that's all I have to say um, about dissociative disorders. Um, Somatic disorders, as well as psychological factors affecting physical conditions. Okay, interesting stuff. And with that, we will move on to our next chapter in abnormal psych. Thank you for your attention, and I will see you later. Have a good one. Bye bye.